Hello, everyone. This is chapter 32. I'm making the tape on pain management. As you guys know, with all types of various conditions, there can be uh, pain. Excuse me, pain. And with pain, there's a lot of different things that you can do, and there's a lot of assessments and things that you can do. And with pain being like really and providing comfort as a nurse, that's one of the central aspects of nursing. Okay, scientific knowledge base. What is the nature of pain? Well, pain is subjective, which means that the person tells you what their pain is, and it's highly individualized. You cannot tell a patient what pain is, and pain coming from the patient is the best indicator of like anything. If a person tells you what pain is, that's what it is to them. You cannot tell them what their pain is. Also, pain, it protects a person from a harmful stimulus. Just like, for instance, you putting your hand on a hot stove and you draw back, and you draw back because it's painful. So, in that form, it protects you from something that can potentially harm you. Like I said earlier, it exists when the patient says it exists. An inability to express pain doesn't mean the patient is pain free. So just because somebody can't express pain, like an infant or something like that, that doesn't mean that that individual is pain free. So with that being said, it's really something that you really have to pay attention to, and you have to make very careful assessments. It's very critical when you're assessing pain. Okay, physiological parts of pain. Um, there are basically four physiological processes, and we're going to go over them, and I want you to make sure that you know them. Transduction. It converts energy produced by stimuli into electrical energy. So, if a person has like a mechanical or chemical uh, type of thing, the injuries release stimuli that cause pain. So, transduction converts that energy produced by these stimuli into electrical energy. The process begins in the periphery. So when a pain is produced, stimulus sends an impulse across the sensory peripheral pain nerve fiber. And those fibers are called nociceptive, nociceptive fibers. Okay? And initiating an action potential. And then once the transduction is complete, transmission of the pain impulse begins. So, for instance, for transduction, you may have a thermal, which is a burn or a frostbite, uh, a mechanical, which is a surgical or incision, or a chemical, which could be leakage of hydrochloric acid into the abdomen. So then you go to transmission. So transmission is the actual cellular damage from injury results in the release of excitatory neurotransmitters. Okay. So cellular damage from the thermal, mechanical, or chemical injury that you had in transduction, the actual damage um, is results in the release of excitatory neurotransmitters like prostaglandins, histamine, bradykinin, and substance P. And these pain sensitizing substances surround the pain fibers in the extracellular fluid, and then it's spreading the pain message and causing an inflammatory response. The pain stimulus enters the spinal cord via the dorsal horn and travels one of several routes until ending within the gray matter of the spinal cord. At the dorsal horn, substance P is released, causing the synaptic transmission from the afferent, which is the sensory nerve, to the spinal thalamic tract nerves, which are crossed to the opposite side. So nerve impulses travel along afferent peripheral nerve fibers, and two of those peripheral nerve fibers conduct painful stimuli. The fast myelinated A delta fibers and the small, slow, unmyelinated C fibers. The A fiber sends a short, localized, and distinct sensation, and the small C fibers relay slower impulses that are poorly localized. For example, after stepping on a nail, the person initially feels a sharp, localized pain. That would be like an A fiber. Within a few minutes, the whole foot might ache. And so then that would be like a C fiber. So you get the difference in what I'm basically saying to you, you know. So you got the transmission, and you got the A, which is that initial sharp, and then you got the slow, which is unmyelinated, and that's the C fibers. Okay, the next, number three, would be the perception. The central nervous system extracts information from the pain impulse. Okay, and then the brain basically interprets that information, such as the location, duration, and quality of the pain. Uh, cognitive factors interact with neurophysiological ones, and then the thalamus is the first structure in the brain to process that impulse. It sends the impulse to many areas of the brain, like the cerebral cortex, hypothalamus, and such, and thus a person becomes aware of the experience of pain and attaches meaning to it. There is no one pain center in the brain that supports the complex nature of pain. Any factor that interprets or influences normal pain perception, such as normal fatigue, depression, or an analgesic, affects a person's awareness and any type of response to the pain. Then you have what they call modulation, which is the neurotransmitters and the reflex response. Modulation is when a person perceives a harmful impulse, the brain releases inhibitory neurotransmitter transmitters such as endogenous opioids, serotonin, norepinephrine, and gamma aminobutyric acid, which they call GABA. The neurotransmitters basically hinder the transmission of pain to help produce like an analgesic type effect, to make it more, I guess you could say, like you're not having that particular pain. And that's a reason why a lot of times people, if they're in pain for a very long time, it may seem like they're no longer in pain as much as they was when it's a quick kind of acute pain. The gate control theory, which is Melzack and Wall, says that pain has emotional and cognitive components in addition to physical sensation. The gating mechanisms is in the central nervous system, regulate or block pain impulse, and then pain impulse pass through when the gate is open and or blocked when the gate is closed. Closing the gate is the basis for non-pharmacologic pain relief intervention. So you have physiological aspects of pain. You have physiological responses. You have low to moderate intensity of pain, superficial pain, and all of that is through the sympathetic stimulation. Then you have severe or deep pain, and that is parasympathetic stimulation. And if it's untreated, it can progress to what they call chronic pain. Then you have chronic pain, which is unrelieved pain and can cause permanent neuroplastic changes. So you have behavioral also responses, behavioral responses to pain. Behavioral responses is the response to pain being more complex, or it's influenced by such factors as a person's culture, ability to cope with stress. A lot of times you'll see behavioral responses to pain, such as a person clenching their teeth, facial grimacing, holding or guarding the painful part, and any type of, like, maybe they'll have bent posture. Also, when you see a person in chronic pain, you can see things affecting them, like they may not eat as good, sleep as good, maybe their hygiene, or maybe they won't have less social interactions. When they're thinking, you may see some confusion or forgetfulness or helplessness, and they can also show signs of being angry or depressed, irritable, or frustrated. So basically, it really can affect a person's quality of life, and it can really be very um, inconvenient when a person is in pain. So, starting with the case study, you got a Mrs. Ellis, and she's a 70-year-old African American woman with hypertension, diabetes, and rheumatoid arthritis. Her current health priority is that the discomfort and disability associated with that rheumatoid arthritis. Arthritis has severely deformed her hands and feet, and the pain in her feet is so severe that she often walks only short distances. The pain interferes with sleep and reduces her energy both physically and emotionally. And as a result of this pain, she tends not to leave her residence very often. Okay, so that's the person that we're talking about this time alone. So, what we'll do is I'm going to give you a description of the differences of the types of acute and, per se, chronic type pain. So, you have what they call acute and chronic pain. Acute pain is transient. So, it could be in any part of your body, it could move, it's protective, it's identifiable, it's a short duration, and usually there's a limited emotional response because it's not going on all the time. People who have acute or chronic pain, they're frightened and anxious, and they usually expect some type of relief quickly. Acute pain is self limiting, and therefore the patient knows that an end is in sight. Okay? So, as long as an acute pain persists, a patient focuses all of his or her energy on that pain relief. Efforts aimed at teaching and motivating the patient towards self care are often hampered until pain is managed successfully. If it's not adequately controlled, it can turn into a chronic pain of some sort. Chronic slash persistent non-cancer pain is unlike acute pain. It is not protective, has no purpose, and may or may not have an identifiable cause. Chronic pain is prolonged, varies in intensity, and usually lasts longer than 6 months. That's usually the threshold. Um, and it's usually like expected or predicted. It does not always have an identifiable cause, as I said, and it leads to what people call great personal suffering. Example of chronic non-cancer pain is low back pain, um, headache, peripheral neuropathy, those type of things. Those type of pains leads to problems such as job loss, sexual dysfunction, social isolation, and they can usually have fatigue, a lack of sleep, anorexia, weight loss, feel seem like they don't care about a lot of stuff, and healthcare providers are usually they are less willing to treat chronic pain with opioids and that type of thing. In addition, um, it, they may see what type of opioids that they could probably prescribe if it goes on, but a lot of times these type of people are the people that are labeled as drug seekers. Then you have what they call chronic episodic pain. It occurs sporadically over an extended duration of time. Chronic pain, uh, the episodes usually last for hours, days, or weeks. And examples of those type of things are things like headaches, people who get migraines, and people that's in like a excuse like sickle cell anemia or something like that. Then you have what they call cancer pain, and not all patients with cancer particularly have pain, but those are those who do as many as 90%. And and they're able to manage their pain. Some patients with cancer have acute and or chronic pain, and the pain is nociceptive and or neuropathic. Cancer pain is usually caused by a tumor progression and its related pathological processes. People having some type of invasive procedures, treatments, and people having infection and physical limitations. And so then you have idiopathic pain. Idiopathic pain is a chronic pain, but it doesn't have any type of identifiable physical or psychological cause. And it's usually considered like it may be an excessive uh, type of pain and syndrome, and research is needing better to identify the cause of what they call idiopathic. Okay, so that is it's a good idea for you to know the difference between those types of pain. So the nursing knowledge base, I'm sorry, I got something in my craw. Knowledge, attitudes, and beliefs. There's misconceptions about pain. A lot of people have misconceptions about various types of pain, and these assumptions about pain, you guys, they can really influence what the nurse is thinking about pain and how they treat pain. Because some people may be thinking that it's maybe somebody that has some type of medication addiction. um, these fears and beliefs lead to mistrust, and as a result, a person can have an increased recovery time because they may not be getting the things that they need. Um, so, patients who are knowledgeable about opioids and make regular efforts to attain them, or drug seeking or addicted. That's what some people think, and that's not always the case. if you cannot find the type of pain that a person has or a reason for it, a lot of times people tend to think there is no pain. They say that some people say that if a person uses analgesics, it may lead to physical drug dependence, and that's not always necessarily the case. Um, they say that the amount of tissue damage and the injury indicates the pain intensity, and that's not necessarily the case. Healthcare workers are the best judge of the existence and the severity of pain. That's a misconception because we already said that it's based on um, what the patient is saying. The pain threshold and tolerance are the same for everyone, and we all know that's not true. Pain is a natural outcome of growing old. Well, there are a lot of older people that don't suffer with pain. Pain perception or sensitivity decreases with age. That's not the case. Uh, Physical or behavioral signs of pain are usually what verifies the existence of severity of pain. And there are a lot of people who don't show accurately how by their physical actions or whatever how much pain is occurring in them. And they also say that a lot of times if a person falls asleep a lot, um, that means they're not in pain. So all these things are not necessarily the case. So you do need to accurately assess the pain in every patient. You need to figure out what the proper therapies may be and evaluate the effects. Factors that influence pain it can be physiological factors like age, fatigue, neurological function, gender. Fatigue heightens pain perception. Um, I mean, fatigue, if a person is tired, um, a lot of times the pain or whatever can be relieved by sleep and rest. But just knowing that a lot of things, like for instance, if it's a cancer patient, it may the effects may be different. Social factors, attention, previous experience, and family and support influences. If you have a lot of people that family and people that support you, you may tend to be able to lessen the effects of pain. A lot of times, if a person has previous experience in pain with some element, like let's say a person went to the dentist and then and they had a lot of pain in that procedure. Well, the next time they go to the dentist, maybe they may feel that that experience is going to lead to them having more pain. So they're almost like thinking it into existence before it occurs. Spiritual factors like a loss of independence and becoming a burden will influence pain because a lot of times people will be going through pain and because they think that it's a burden on somebody or because they it or because they're losing their independence because for instance maybe they can't walk as good because they're in pain could influence how or what their level of pain will be. Cultural factors influence reaction and or expression of pain. um, uh, like they try to say, they say that chronic pain typically tends to affect, as far as in gender, women more greatly. Uh, and they say that might be related to, hormonal levels and that type of things like that. So all of these things or how a person looks at pain can be an influence on pain itself. Uh, so there are physiological factors that you have to look at. You have to look at the meaning of pain. What does the patients may perceive pain differently if it suggests a threat, loss, punishment, or some type of challenge? Whether or not the person is anxious. So if a person is more anxious, um, the presence of anxiety in the patients may have a negative influence on like chronic pain. Patient nurses, they need to reduce health anxiety levels to lower pain perception. Depression, the incidence of depression is very high in patients with chronic pain. The experience many uh, losses each is their ability to enjoy life, be in the control, work, socialize, and be independent. So, suicidal thoughts are relatively common, therefore, you need to routinely assess for suicidal tendencies. And then, coping styles. You may have heard of internal or external uh, Loki. In contrast, patients that, like for instance, somebody has internal Loki of control perceive themselves as having personal control over their environment and the outcome. Somebody who has external Loki could perceive other factors in their environment, such as the nurses and that type of thing, being responsible for their outcome as far as it relates to their pain level. Of course, critical thinking knowledge. It's important for nurses to have knowledge about the physiology of pain and disease process. It's important for us to have adequate communication skills so that we'll uh, be able to enhance how thoroughly we assess people for pain and uh, be knowledgeable about non-therapeutic and therapeutic. I'm sorry, not non-therapeutic, non-pharmacologic and pharmacological ways to relieve a person's pain, such as when we talked about attention in the last slide. Attention, there are a lot of distraction methods that people use to try to get people's I just try to get them away from pain. People use things like music therapy, all types of things to try to help a person uh you know work or deal with their level of pain. Experience, clinical and personal. um like the degree of pain affects their behaviors and their actions, and how long they take to find reliefs. How you have experienced pain, how you've seen things or seen people experience pain may interfere with your ability to effectively treat pain. Because if you come in there with a notion about certain types of pain, then you may, you know, not do as much, for that person's pain. Attitudes like perseverance, integrity, and responsibility uh, plays a big role because as a nurse, you are supposed to persevere to find an approach that offers a patient a degree of um, treatment. So the perseverance is very important. Integrity is important, uh, as well as how you feel about how responsible you are as far as accepting or using different approaches to try to relieve the person's pain level. Then standards, just whatever intellectual professional standard guidelines and any type of position statements that you use will make you, like for instance, there are what they call three standards for healthcare organizations to follow and when they're managing pain. So you may recognize the right of a patient to appropriately assess and manage management of pain, proper screening for patients during their initial and reassessments, and also the ability to educate, the person on their level of pain. So determine which level of pain will allow your patient to function. And when the patient is in acute pain, assess location, severity, and quality. When the patient is more comfortable, then you can collect a more detailed assessment. And the reason why they say while the patient is more comfortable is because a lot of times that PQ or STU, a lot of things people will not answer correctly because they're focusing just on the pain. So they want you to take care of that physical first. Like we say with Maslow's, take care of that physical first. And then after you do that, then a lot of times you can get even a little bit more from them concerning their pain. So pain can constantly change, and monitoring it on a regular basis along with other vital signs can tell you a lot. Okay, so during the nursing process, you're going to look at the patient's expression of pain. Patients may not volunteer pain status always ask and recognize nonverbal expressions of pain. And we've talked about this, things like grimacing and that type of things. Although some people, um, may not do it as well. You have people who are, because it's like really individualistic, just like how people grieve can be individualistic, but there are some things that you can look for. So there is a list of patients that are unable to self-report pain. You have people like infants and children, patients who are critically ill or unconscious, patients with dementia, patients who are mute or aphasic, and patients with intellectual disability, and then patients at the end of the life. So with these patients, you're going to try to just do the best that you can, and you're going to try to look if there's any other type of cues that they can give you. Like for instance, like we say, the grimacing. Maybe you will see somebody in tears. Sometimes when you take your vital signs, there'll be if depending on if it's acute or if it's chronic pain, there may be an elevation in the vital signs. A lot of times there's elevations when there's more of acute uh, pain. And then because if a person's been in pain for over 6 months or so in that area, a lot of times your body tends to self-regulate. Okay, so nursing process. We've already talked about the characteristic because we've had y'all do the uh, PQRST U. So timing, precipitatory factors, quality, relief measures, region, which is location, severity, and effect of pain on the patient. So those are some of the most important things that you need to assess when you're assessing for a patient. Also, assessing pain in children. Assessing pain in children can be difficult at times, but they do have the Wong Baker faces that you can use with children as far as assessing pain. And as you can see on the chart, it'll have 0, it'll be a happy face, all the way down to 5, which shows like crying on top of the grimacing. So you may want to look at that Wong, and it'll show you, about a patient's level of pain. Okay. Concomitant symptoms occur with patients and usually increase pain intensity. These include stuff like nausea, headache, dizziness, urge to urinate, constipation, depression, and restlessness. Certain types of pain have predictable symptoms, and stuff like that. For instance, if a person has a rectal pain, they may tend to be more constipated because they don't want anything to come through there. So these symptoms are as much as a problem to a patient as actually, the pain itself. Patient expectations. If a patient, uh, they have to have recognition of relief of pain and prompt response. Usually, patient relies on the caregivers to recognize and alleviate the physical discomfort. Uh, Always ask the patient what they expect regarding their comfort needs. What do they want? And see if you can clarify that and see if you can get a prompt response. So after you do assess and do everything, you're going to report the pain. You're going to assess the effectiveness of any interventions, anything that you do, and you're going to always use the same assessment tool to reassess the patient because you don't want. I mean, you don't want to use something different because you wouldn't have what we call effective um, assessment. So, quick quiz. When the smiling, cooperative patient complains of discomfort, nurses caring for the patient often harbor misconceptions about the patient's pain. Which of the following true? Chronic pain is psychological in nature. Patients are the best judges of their pain. Regular use of narcotics leads to drug, and amount of pain is reflective of actual tissue damage. Uh, Patients are the best judges of their pain, would be the answer. That would be B. So Jim is a 26-year-old nursing student. He's the one that's going to be taking care of Miss Ellis. Jim conducts assessments and he does his thing like what we're going to do. When Jim enters Mrs. Ellis's apartment, he finds the house is in disarray. That is very common because if you're in pain, you're unable a lot of times to take care of that if you don't have anybody. So that he finds her sitting on the recliner, clothing on the floor, soiled dishes, um, that she was telling him, you remember she had that rheumatoid arthritis that it was difficult to use her hands and walk between the rooms, and she is able to get to the bathroom, but it does cause her an extreme amount of fatigue, and her pain is constant and is localized in the joints in her hands and her knees. So we do have nursing diagnosis, risk for caregiver role strain. That is a lot. Ineffective coping, fatigue, impaired mobility, acute chronic pain, bath, self-care deficit, dressing, self-care deficit, risk for situational low self-esteem, and social isolation. You can relate all those nursing diagnoses to pain. So Miss Ellis, she responds to lead Jim to the nursing diagnosis chronic pain related to joint inflammation. Okay, so that's that rheumatoid arthritis. So the chronic pain is related to joint inflammation, and that's evidences by um, a 4 on scale of 0 to 10. And so she has been taking aspirin, but the pain prevents her from falling asleep. If she does sleep, she often reawakes, and she has difficulty standing and she got unsteady gait. So the goals is to set goals for pain relief and level of function and make it something that's measurable and make it something that really works for that particular patient and their particular setting. Okay, and then collaborate with a bunch of family, friends, specialists, and make sure you always document. So, the nature of the pain and extent of effect determine the choice of pain relief therapies. So, you're going to implement previously successful pain relief remedies. If something's not working, what's the point of using it? Try the least invasive and safest therapy first. You'll always say that about me. Less is more. uh, non uh, assistive personnel may screen patients for the presence of pain, health promotion, and maintaining wellness. So there are non-pharmacological, which means they're not pain medicine per se. You can use reducing pain, uh, reception and perception, anticipatory guidance, distraction, cutaneous stimulation, and relaxation and guided imagery. So those are some of the things that you can use and some of the things that you can do that are non-pharmacological, that you can use on a person. So if you're gonna do, like, for instance, reducing pain, reception, and perception, you could do a lot of little different things. Whatever noxious stimuli is around, you're gonna make sure that you get that around away. If a person can have wrinkle linen, and you might need to smooth it out, uh, you may use something. There may be a device that they're using that's rubbing up against their skin that you can correct. There are various different ways that you can correct um, using those type of things to help. Distraction, like I had told y'all, relaxation, and guided imagery. So there's a lot of different things you can do. Now, acute care, they do have pharmacological. You can use analgesics. You can use a PCA, local anesthesias, epidural. Those are various types of ways that you can use to assist pain. Okay, so you have patients with cancer pain. Um, and what they usually do is they use that 1, 2, 3 method, as you can see. And so you'll use a non-opioid, and if the pain is increasing or whatever, then you'll go to the opioid for mild to moderate, and then it's persistent. Then you go to the opioid for moderate or severe. So what they're trying to say is they start off with one type, and remember I said less is best or less is more, and they go up, you know based on what the relief of the pain can be. So Jim discussed uh modifying anti-rheumatic drugs, um, to, like, maybe an NSAID. And then Jim had Miss Ellis take analgesics approximately 30 minutes before she do any type of activity. Okay, so Jim also suggested placing a sturdy stool in the shower stall and run warm water continuously over the joints of the hands and the feet. Apply moist, warm compresses. Refer to a physical therapist. Uh, and probably with her, since she got the problems with the arms or the hands and stuff, OT as well. Uh, a patient has just undergone appendectomy. When discussing with the patient several pain relief interventions, the most appropriate recommendation would probably be PCA initially, and then taking it down because of the fact that the person just came out of surgery. So you have restorative and continuing care. You may have opioid infusions, uh, failure of pain control medications with chronic care, palliative care, and hospice. Palliative care is basically keeping a person comfortable. And of course, you guys know that hospice is for, end of life care. A post-op for patients using a PCA, you will evaluate the effectiveness of this medication when you compare assessed pain with baseline pain. Because prior to you having a person in pain, you're going to see where they are as far as pain. So if they're using a PCA and maybe you might want to come down, a little bit. Maybe they might tell you, well, I'm not on any pain now. So you might even decide that it's time to take them off the PCA and put them on something else. When Jim observes Miss Elder's ability to stand and walk from the living room, she was able to ambulate with the walker. Her gait was slow but steady. Mrs. Ellis reported that she has less discomfort from bathing, and that was related on the non-pharmacologic efforts that Jim offered to her. And then Miss Ellis rates her pain at 2 after taking the analgesic, when at first it was 4 after taking it. Patient care, the patient is the source for evaluating the outcomes because, like I said before, nobody can tell you about somebody else's pain. And patient expectations, assess the patient behaviors, ask the patient if expectations have been met, and use open-ended assessment questions. So, for safety, be vigilant during the entire process of medication administration. Take care of yourself. You think as clearly and critically as possible if you are healthy, and set up and prepare medications in distraction free areas so that you won't get your medicines mixed up and make a medication area. So, after Jim had assessed Mrs. Ellis, she had gone to see a nurse practitioner who prescribed NSAIDs. She has not filled the prescription and is still taking her aspirin, but continues to have some gastrointestinal irritation. Jim gets the chance to observe Miss Ellis using a warm compress on her hands, and notes that her gait is steadier. Miss Ellis has spoken with her nerver, who has offered to help with shopping. So basically, I think they got her a little bit where they needed her to get. Don't overjudge. Don't over think it. Don't over make somebody go through the things that they may not need to do. Uh, I do want you guys to look into the various different things that you can do for a patient. For instance, let's say you got people that's getting epidurals. I want you to know what an epidural is, or a regional, or a local. Know the difference between local anesthesia, regional anesthesia, epidural anesthesia, that type of things, and know what to expect when you see somebody getting those type of infections. They have some wonderful charts that are kind of show you about what type of things and stuff in your book as far as patient and promoting better ways to treat patients when they're in pain. And I think that would be it. And so you guys have a good one. Thank you.